Oh no, it'll start recording you now, but it won't start.
So good evening, everyone. Today we're here joined by Dr. Steve Morgan to talk about universal PharmaCare. This is one of the first times we've ever conducted a broadcast such as this. So please excuse if we have any technical difficulties. We're available if you need to answer any questions or if you have any complications, we'll also report that. So without further ado.
Thank you, and hopefully this headset will work out tonight. So thanks for those of you who are here, and also for those online interested in learning a little bit more about PharmaCare. This is going to be a little bit like a standard, I guess, classroom lecture in the sense that I'll give a presentation about universal PharmaCare. And I think now we can call it a hot policy topic of the day in healthcare. And then we'll open it up for questions, and happy to chat with you about the various issues. The theme of the talk, which I actually just modified these slides today to try to cover off sort of why we would do PharmaCare, how we might do PharmaCare, including some of the popular options on the policy table, and when we might do PharmaCare. And to ask the question, is now the time, or is it something that might be required later? So going through the why, how, and when. I think that the answer to why PharmaCare actually follows from international human rights law. Students of health policy and health professionals in Canada might be surprised to realize that Canada is a signatory to numerous declarations at the United Nations and the World Health Organization that clearly enshrine access to healthcare as one of the fundamental human rights. It's non-negotiable in terms of our government's obligation to ensure that all citizens in this country have reasonable access to necessary healthcare, including universal and unimpeded access to necessary medicines. Now, consistent with that fundamental human right, every high-income country that has achieved universal healthcare coverage also offers universal coverage of prescription drugs. Every such country with the exception of Canada. And to be honest, if Canadians find that our Medicare system is based on principles that we should be proud of, principles of equitable access to high-quality healthcare regardless of ability to pay, but based solely on a patient's need, then our lack of coverage to equitable access or a lack of equitable access to necessary medicines, regardless of ability to pay, but based only on need, should in fact be a source of national embarrassment. So we could almost end the why PharmaCare there because we're the outlier. We are the only country that has not yet fulfilled this fundamental human right of ensuring that Canadians have access to necessary medicines. At the very least, access to essential medicines as defined by the Model Essential Medicines list of the World Health Organization. And it's somewhat embarrassing to know that dozens of middle and low income countries actually achieve universal access to those sorts of medicines, and we in Canada have not yet done so. Canada pays for medicines through an interesting kind of patchwork of private and public sources of financing that is quite unique around the world. We often hear about this idea that Canada's healthcare system is 70% publicly funded, but that only applies to the system as a whole. When in fact, when you break the system into pieces, you have very different systems of financing. As many Canadians are aware, as it relates to hospital and medical care, our system is almost exclusively publicly financed. In this bar chart or pie chart sort of here, the public system of financing is the dark blue. And public insurance plans in Canada cover, for hospital and medical care, about 90% or more of the costs of those services. When it comes to pharmaceuticals, public drug plans cover about 42%, or roughly 40% of the costs of prescription drugs used in Canada. Private drug plans account for about a third of total expenditures on prescription drugs in Canada. And this is because about 2/3 of workers have access to extended health benefits in Canada that provide them with medical, or I should say dental prescription vision care and other forms of extended health insurance through a private insurer. And about 25% of prescription drug purchases in Canada are financed out of pocket by patients that are either uninsured or underinsured in the context or in the sense that they either pay for all of their drug costs below a deductible, like in British Columbia, where your deductibles are set according to the provincial drug plan in relation to your income. Most British Columbians pay 3% of their household income on prescriptions before benefits kick in under the public plan. Some people obviously are also effectively underinsured under private plans if those plans also involve deductibles, or if those plans involve contribution limits so that the patient has to pay for drug costs above a certain amount, or if those plans have carve-outs, so certain aspects of pharmaceutical treatment just simply aren't insured by the particular group. So an interesting mix of private and public plans. This gives us a portrait here of very many Canadians actually being in the situation of being under or uninsured for prescription drug costs. In 2015, the Angus Reid Institute did a national survey to ask Canadians what was their access to medicines like, and how well covered they were. And these statistics are the percentage of households that reported that they were either uninsured in the sense that they paid for all of their prescription needs out of pocket without either private or public coverage assisting them with their costs, or whether they were underinsured in the sense that they paid for half or more of their total annual prescription costs with some assistance from either private or public drug plans. Roughly 20% of the Canadian population, or 20% of Canadian households, reported being in that status. And in fact, it breaks down nearly 50-50 in the sense that about 10% of the population reported having no drug coverage at all, and about 10% of the population reported having less than complete coverage in the sense that they had to bear half their costs. You'll notice that British Columbia is one of the highest rates of under or uninsured populations. That is in part because our system of public drug benefits in this province is based on the catastrophic coverage model, where patients or families have to pay a given percentage of their household income before any public subsidy kicks in. So a considerable number of people, for instance, who are over 65 are underinsured, even though technically speaking, they are beneficiaries of a public program. Similar programs exist in Manitoba and Saskatchewan, and not surprisingly, those provinces also reported higher rates of the population being either without insurance or still having to pay half or more of their drug costs, even though they're technically covered by an insurance plan. Now, this translates into access barriers. It's been reported time and time again. I myself have authored now 7 peer-reviewed research papers on what's called cost-related non-adherence to prescribed medicines in Canada. 7 papers over the last roughly 12 years, drawing on 6 or so different international or national surveys. This again is the same Angus Reid Institute survey asking households whether any member of the household reported that they didn't fill prescriptions as given to them because of the out-of-pocket costs. And again, roughly 1 in 5, about 20% of the population of Canada, reported skipping prescriptions at a household level as a function of cost. And again, you'll see that British Columbia actually has the highest rate of this reported access barriers to medicines in the country. That's consistent not just with this Angus Reid Institute survey, but repeated surveys by Statistics Canada, by the Commonwealth Fund based in the United States, and by other organizations that have surveyed this phenomena. British Columbia, perhaps owing to its catastrophic drug plan nature, has some of the highest cost-related non-adherence as the rest of Canada does. So we have both gaps in coverage, and we have some serious access barriers in Canada. And for that reason, it has been recommended numerous times that, like every other developed country, Canada should in fact not just offer universal coverage of medical and hospital care, but should also offer universal coverage of prescription drugs. And this recommendation goes way back to the origins of Canadian Medicare. In fact, I haven't listed the Haggerty Committee report in 1943, but the original blueprints for Canadian Medicare included a more comprehensive system of insurance, one that would have included not just hospital insurance and insurance for physician services, but also insurance for prescription drugs, and of course, with that, the pharmacy services that comes with prescriptions. This goes back to, to the Hall Commission in 1965, the National Forum on Health in 1997, and the Romano Commission in 2002. We're waiting right now to find out whether or not the Parliamentary Standing Committee on Health will make a similar recommendation. The last 2 years, they've been having hearings in Ottawa concerning the odd idea of a national PharmaCare program, and we'll see what the recommendations of that commission or that committee are. It was expected that those recommendations might be up literally any day, possibly even as much as a month ago. I don't expect we will have to wait much longer than to the end of the spring before Parliament recesses for summer. I think we'll see that report. So, repeated recommendations time and time again. Likely a similar recommendation is going to come down the pipe from government yet again in 2018, that we need to have some form of universal drug coverage in this country. So the question is, how should we make our PharmaCare system? What should it look like? And what lessons can we learn from both the research literature and international experience? And this is an area which I've done a lot of work. I've actually been studying issues around how countries approach drug coverage, evaluation, pricing, regulation, and promoting appropriate prescribing for over 20 years. And the last 12 years, I've been lucky enough to host annual meetings of policymakers responsible for managing drug benefit programs in high-income countries that Canada would compare itself to. Roughly maintain regular interaction with 10 to 15 high-income countries around the world that we can learn lessons from in terms of how they run their systems. And I've also done a lot of academic research looking at the peer-reviewed research around what are the effects of different policies, what are the effects of how patients respond to changes in coverage level and access. And from that body of literature and international experience, we've extracted, my colleagues and I, a few lessons about what we might call PharmaCare design that are really important to achieving the key goals of accessible access to medicines, financial equity in terms of the distribution of burden on households, appropriate prescribing in terms of making sure we incentivize the appropriate use of medicines and not overuse, and finally, system efficiency and sustainability, so that we make sure that prescribers, patients, and health system managers are carefully considering the costs and benefits of medicines being prescribed. Because very often, prescription drugs are the most cost-effective way of addressing healthcare needs. But sometimes prescription drugs get overpriced, or perhaps if they are not as safe and effective as alternatives, including other prescription alternatives, those are not necessarily the best ways of treating patients within the health system. So we have a few design considerations that come out of the literature and international experience. And one of them is that coverage matters. If you want to encourage access to necessary medicines, you have to make sure that you take away any form of financial barrier to having patients fill prescriptions. And as pharmacists today or pharmacists in the future, you will become intimately familiar with the reality that when faced with any charge for a prescription, particularly a prescription for an asymptomatic or subclinical risk factor, patients will often make a choice that is appropriate to them and their circumstance, but maybe not in the best interest of the broader health system, insofar as patients, when faced with user charges or lack of insurance entirely, are just as likely to stop taking essential medicines that will maintain their good health as they are to stopping medicines to treat more discretionary symptoms of disease and symptoms that might cause them discomfort. So coverage will matter in system design. We also know that purchasing power matters. Pharmaceutical manufacturers are very powerful corporations, not only because of their size, and it's something that maybe not a lot of Canadians know, that top 3 pharmaceutical manufacturers each individually have more global sales than the entire GDP of each of 6 of Canada's provinces. These corporations are bigger than many of our provinces in Canada. They have a lot of power in the world market, but they also have power conferred upon them by us on purpose. We grant pharmaceutical manufacturers patents, that is a form of intellectual property, in the hope of inducing innovation and creating an incentive for the research and development to bring products to market. In a market like healthcare, though, that power, that monopoly power of intellectual property can potentially be abused because the buyers of the technology that is produced are often in a state of great vulnerability. They're in an economic sense, they're in a state of very inelastic demand. If they really need a treatment, they'll pay anything for it, or they'll insist that their governments pay anything for it. So purchasing power matters in this marketplace. If you have firms that are selling products with significant market power on the supply side, when you have a system of buying medicines, it is better to have buyers that have significant power on the demand side. When you have multiple purchasers, multiple insurance companies, for instance, and multiple different public drug plans in the same market, it works a bit like an auction in the sense that it doesn't drive prices down. It tends to drive prices up relative to a system that would have a single payer or a single purchaser. We also know that financial incentives matter, and they matter in a couple of ways. In terms of health system management and thinking about promoting the best possible health gains for a population out of available resources within a healthcare system, it's very important that managers, prescribers, and patients recognize that there aren't silos in how we fund healthcare, but that there is an integrated sense in which the money that is spent on medicines can and often is the most cost-effective way of promoting the health of a patient and promoting the health of the population. But it is money that is simultaneously not available for providing other forms of treatment to the patients, not available for hospital care, not available for medical care, not available for mental health treatments or long-term care. And so as a consequence, it matters that the system for managing pharmaceuticals be well integrated with the system for managing hospital and medical care so that those incentives for performance and efficiency are aligned at a system level. There's another degree to which financial incentives matter, and that's in the actual financial transactions in a system of reimbursing medicines. It's fairly rare around the world, particularly amongst comparable countries, that systems allow for there to be profit in the insurance of medicines. And the reason for that is that when there is profit in the insurance system for medicines, there actually becomes a reduced incentive to ensure that medicines are priced at a level that represents value for money, and specifically that medicines are priced at a level that represents the most competitive, best available price in the world, because oftentimes insurers make their money based on an administrative fee that is proportionate to the total claims that go through their systems. So the profit incentive essentially of the managers of the system will be very important. And I'll show you in a few minutes how that can bear out in terms of costs. So what I'd like to do is turn to a few international comparisons and say, okay, if we think these design considerations matter, can we trace them in terms of the outcomes that are important, like access to medicines and system costs? And we're going to compare Canada to a number of high-income countries with universal health insurance systems. And I'm just going to draw your attention to this, and for those of you online, I apologize, it might be a little difficult to see this, but this is a number of countries organized so that the universal public healthcare systems of the world, or at least 5 of those systems along with Canada, are up top. That includes New Zealand, the United Kingdom, Norway, Sweden, and Australia. Canada's in the middle in red. And at the bottom are the social insurance systems of Europe. This includes the Netherlands, France, Germany, and Switzerland. The difference between universal public healthcare systems and social insurance systems is basically public systems are universal single-payer healthcare systems. Social insurance is universal but multi-payer health insurance systems. So patients in those systems, either by way of their occupation, get assigned to what's called a sickness fund or an insurance plan, or they can go into a market like they have in places like the Netherlands and Switzerland and buy their health insurance from a social insurer. Social insurers in those contexts are very highly regulated, so they're a little bit different than what we would think of as private insurance in Canada. But nevertheless, there's more than one of them. So that's how these systems organize themselves in broader healthcare financing, and Canada is indeed a universal public health insurance system like the ones at the top. It's colored in red partly because we're Canada, but also because our system of drug coverage is so different than every other system that it's important to note that. So in terms of the system design considerations for pharmaceuticals, I just very quickly show the data, for instance, on whether or not prescriptions are universally covered in those countries. And this is that story, that Canada is the only developed country, at least of this bunch, and in fact of any bunch that you can find, that has universal health care but doesn't have universal prescription coverage. But within that, it turns out that some of these countries allow there to be fairly significant user charges or patient charges for people who need prescriptions. Most of the countries have a pretty good system of protecting patients from costs out of pocket. In many countries, the cost that patients pay per prescription are about $15 or less than that per prescription in those comparable countries. In places like Wales, Scotland, and Northern Ireland, the charges are zero for prescriptions covered under their universal drug benefit, on the belief and philosophy that patients aren't going to abuse the system, and prescribers certainly aren't going to write unnecessary prescriptions when they recognize that the money coming from medicines is also coming out of the budgets for the rest of the system. And I'll talk about that later. Australia, I covered the color coding is sort of green is good, yellow is cautionary, and red is bad. Australia is sort of bad in the sense that they have a universal public drug plan for Australia. It covers all Australians in their federation. But the cost per prescription is about $35 per prescription. There are concessionary benefits that will give people lower prescription costs if they're over age 65 and meet other criteria. But on average, that's a much higher prescription charge than you see in comparable countries. And then Switzerland at the bottom here actually allows people to buy high deductible insurance for their care, a bit like British Columbia's catastrophic drug coverage. That high deductible insurance applies to all of their care, hospital, medical, and pharmaceutical, but specifically as it relates to the pharmaceuticals, you can expect that this might result in people just not filling prescriptions because of the out-of-pocket costs, because under those systems, people would be effectively uninsured, at least for the first few prescriptions that they fill in a year. In fact, in some cases, it could be for the first few dozen prescriptions that they fill. Other design considerations in terms of the market power and efficiency side of the system, how many of these systems are single-payer pharmaceutical systems? And this is where the breakdown is right across the line. Universal public systems of health insurance around the world all have universal public pharmaceutical insurance. There's no universal public health insurer that we would compare ourselves to anyhow in Canada that decides to have pharmaceuticals carved out. We're in red because we are unique in the sense that we don't have a single-payer PharmaCare system to go along with our single-payer Medicare. Social insurance systems of Europe, by definition, are multi-payer systems, both for pharmaceuticals and for medical, hospital, dental, and all other care that you would insure for. So we expect that will have some impact in terms of the power of these systems to negotiate prices. The system integration is an important consideration in terms of thinking about whether prescribers, patients, and managers will in fact worry or concern themselves with value for money of one product versus another when they're using the resources from the system. And countries like New Zealand, and the United Kingdom have fairly highly integrated financing systems where essentially the money that comes from the system that pays for hospitals and doctors is right from the same budget at a local level that would pay for pharmaceuticals as well. Countries like Norway, Sweden, and Australia have slightly different levels of government organizing their healthcare systems and their pharmaceutical budgets, but nevertheless, they still come from the public purse at the end of the day. Canada's, as we talked about, is very unique in that we have a highly fragmented system of public coverage universally for hospital and medical care, and actually very minority state public financing of medicines, where again about 40% of the budget is publicly funded for medicines, and most is financed through the private sector. The social insurance systems of Europe are interesting insofar as they, for the most part, actually integrate financing of medicines and medical care together into the same sickness funds. There's just one little minor glitch with France, insofar as in France you can have parallel supplementary private insurance on top of the social insurance as it relates to a system to pay for your deductibles and co-insurance for prescription purchases in France. And colleagues of mine report that about 90% of the French population actually has this add-on insurance, not to cover the drugs themselves, but to cover the co-insurance or the co-payments that the French system requires patients to pay for their pharmaceuticals. And it's in that kind of dual system that they end up getting universal coverage with little or no co-payments in France. And then lastly, what systems allow there to be profit on pharmaceutical insurance coverage, the system of financing the medicines. And this is also interesting and telling insofar as Switzerland does allow profit to be in their multi-payer private social insurance system. The Netherlands, which is often talked about as the social insurance system that was the model in some sense for US Obamacare, actually explicitly prohibits the insurers from taking a profit on that insurance system. All of the surplus above the revenues collected, and after taking out all the payments for all the care provided for a population, all that surplus has to go back into the system, into providing new forms of care for the patients served. The shareholders of the companies that run that social insurance system are not allowed to take that home as income. But in Canada, of course, we have a system where, for the private sector anyhow, for private insurance, beginning in the late 1990s, we demutualized that industry. We basically allow there to be for-profit life and health insurance in Canada. And now there are very significant for-profit players in the pharmaceutical benefits world in Canada. There are, of course, not-for-profit private drug insurance companies or insurance companies in Canada. And of course, our public insurers are not-for-profit as well, just as is the public insurer in all of the other universal public healthcare systems. So that's a lot of information about comparative policy to give us a sense of where Canada is at, but the color coding says it all. If you were thinking that green is good, yellow is cautionary, and red is bad, there isn't a metric by which the Canadian system is good. Not one. We fail on all of these major metrics in terms of what we think will promote access to care and what we think will control the costs of the medicines being used by a population. And almost all of the other systems do reasonably well on other things. The social insurers doing less well on their single payer purchasing power in the world, but reasonably well on other things. And if you were to guess the systems that perform best in terms of access and costs, it would be New Zealand and the United Kingdom. And the UK is not a bad comparable to us because we often compare our system to the NHS. Theirs is a slightly different governance model, but it is still very much in the tradition of universal public coverage for all, regardless of age, income, and access based on the ability to pay. So, what does this mean in terms of effect on access to medicines? You've heard the stats. I've already given you the Canadian stat, particularly the Angus Reid Institute survey, but you've probably also all heard repeatedly the statistic that at a patient level, about 1 in 10 Canadians that is given a prescription chooses not to fill that prescription because of the out-of-pocket costs. That's an extraordinary statistic, but in the international context, it becomes even more extraordinary when you look at these data. Again, I've color-coded things so that we can look at the universal public systems on the left and the universal social insurance systems on the right. Single payer, multi-payer. And just as I said earlier, that all of these systems have universal coverage. Australia and Switzerland, however, have some gaps in the sense that some people might be underinsured or people might pay a high cost per prescription. And it does show up in the data in terms of these bars are the percentage of the adult population reporting that they didn't fill prescriptions as prescribed for them in 2016. So this is quite recent data, owing to the out-of-pocket costs of those prescriptions. So you've got Canada, in this international survey, it's 10.2% of our adult population reporting this. In the single payer public systems, it's 3.6 averaged across all those systems, and in the multi-payer systems, it's still very good, 3.8% averaged across those countries. And the averages are population weighted, so that Switzerland doesn't dominate, for instance, Germany and France, which are much bigger than Switzerland. And similarly, that the smaller countries like Australia and New Zealand don't dominate vis-a-vis places like the United Kingdom. Now, to give you some context, that difference between Canada and these countries abroad is quite significant clinically. If you think about the fact that if we were to be able to bring our national average of access to medicines down or up to the level of these countries abroad, or the barriers to accessing medicines down, about 2 million more Canadians would fill prescriptions that they're foregoing today. And there's a number of important stats that have been out recently, not all of which have caught a lot of attention, but I think they're worth revisiting here. One is the 60 million figure, which came out of the Parliamentary Budget Officer's report on the National PharmaCare program that was delivered to Parliament just last fall. Everyone paid a lot of attention to the Parliamentary Budget Officer's financial reporting in that report about PharmaCare. Well, I mean, a PBO, a budget officer, is supposed to be the national accountant, so to speak. But one of the things that the economists within the PBO's office did was model the likely increase in utilization of medicines in Canada that would occur if we had a system of drug coverage that resembled the system in the United Kingdom. Similar co-payments and similar exemptions for certain populations. The Parliamentary Budget Officer estimated that Canadians would fill 60 million more prescriptions than we are filling today if we had a universal, comprehensive, and public pharmacare system. 60 million prescriptions is quite a few prescriptions, and one would assume that some of those prescriptions, hopefully all of them, would be prescriptions for things that patients really needed. And in fact, it's borne out in some of the data. We did look at international experiments with changes in the level of coverage. You do see that when you provide more coverage, patients fill more prescriptions, including prescriptions for essential medicines that keep them out of hospitals. And then in the Canadian context, just a couple of weeks ago, my colleagues and I from here at UBC at University of Toronto and Simon Fraser University, we produced a paper based on the 2016 Canadian Community Health Survey of Statistics Canada. And in that survey, one of the questions that was asked was whether or not patients who did experience access barriers to medicines that were prescribed to them, whether they felt that they used more resources. And projected to the Canadian population, we estimated that approximately 100,000 Canadians essentially perceived themselves to have foregone medicines that resulted in their needing more hospital services, whether that's visiting an emergency department or actually being admitted as an inpatient. That's 100,000 Canadians using essentially our overburdened healthcare system as a consequence of the fact that we don't provide them with the kind of prescription coverage you might find in virtually every comparable high-income country. But this last statistic is one that I think it really captures one's imagination when you really think it through. And this is 700 that comes from a paper written in 2012 by Gillian Booth and her colleagues at the University of Toronto, where they looked at diabetics in Ontario above the age of 65 and diabetics in Ontario below the age of 65. And the age of 65, yeah.
Oh, we actually have a question from online. So it's from BC. Edward Fang asks, lots of talks around PharmaCare, and I believe it's an excellent idea. However, PharmaCare is essentially an agreement to reduce drug costs among other initiatives. As a community pharmacist, our revenue is designed around products and retail markup. It'll be difficult for community pharmacy as a profession to continue to be sustainable under a national PharmaCare. Are there any talks to include fees or reimbursements for clinical services by pharmacists in these PharmaCare talks?
Yeah, we'll get to that later, but the question, just for those of you who couldn't hear, was, what are we going to do about revenue for community pharmacy? And certainly, reducing the cost of prescriptions will have an impact on revenues to community pharmacy, but no one's arguing that one would reduce, for instance, the professional fees that pharmacies get for dispensing medicines. If we saw 60 million more prescriptions flow through the pharmacy shelves in Canada, That's 60 million more professional fees that pharmacies will be collecting under such a system. And that was, in fact, included in the PBO's estimates. But getting back to this statistic here, Gillian Booth and colleagues looked at patients who had diabetes in Ontario who were over age 65 and patients in Ontario who were under age 65. And that's an important breakpoint in Ontario because people in Ontario over 65 have relatively comprehensive public drug coverage under the Ontario Drug Benefit System, the ODB. And people under the age of 65 don't have that public coverage. They have kind of British Columbia-like catastrophic coverage if they have very high costs under a system called Trillium. And they have the option, if they're lucky, to have employment-related extended health insurance from the private sector. And what Gillian Booth and colleagues found was that diabetics in Ontario, their treatment and outcomes had much greater socioeconomic gradients, that is, much greater differences between rich and poor when patients were under the age of 65 than compared to patients over the age of 65. And Booth and colleagues argued that much of that would have been due to the differences in access to medicines necessary to manage diabetes and related risk factors. And they came to a conclusion in their paper that the difference in access to treatment and outcomes across incomes between those two age groups was sufficient to explain about 700 premature deaths in Ontario every year over a study of 6-year follow-up. 700 deaths per year is the equivalent of a plane full of Canadians crashing to the ground and everyone dying every year, possibly even every month if you were to extrapolate that to the national level. And so we're talking about a situation where access barriers in this country are probably, quite plausibly, causing formidable harm to Canadians. Not just increased use of a health system that is already overburdened, that we as taxpayers are already going to pay for, but also real substantial harm to the quality and quantity of life of patients who need treatments that they're unable to access. So what about the effect on cost of medicines? The other side of the goal here in terms of, we have system designs like we see abroad, what would we expect in terms of the cost of a drug plan? And this is the real punchline. All of those other countries we compare to have better access to medicines in terms of population's rate of reporting that they are able to fill the prescriptions that their doctors or nurse practitioners give to them. But in terms of cost, what's really quite stunning is that all of those countries also pay a lot less than Canada does. Again, organized so that it's the universal single-payer systems on the left and universal multi-payer systems on the right, and Canada in the middle. You can see that Canada on a per capita basis spends more on pharmaceuticals than any of these comparable countries. Just slightly more than Switzerland or Germany, but to give you an idea, if we came down to those levels like you see in Germany, Canada would be saving somewhere in the neighborhood of $4 billion a year. If we came down to the level of the average for universal multi-payer systems in Europe, Canada would be spending about $826 per capita and saving somewhere in the neighborhood of $5 or $6 billion a year. But what's really striking is if Canada was to bring itself down to the level that you see in single-payer systems abroad. So every comparable healthcare system that is a universal public system spends considerably less than Canada does on its medicines. If we were to come down to the level that Australia spends, we would be saving about $7 billion. If we were to come down to the average of these comparable countries, we would be saving somewhere in the neighborhood of about $10 billion a year. That's very considerable differences in spending, and it's notable that the single-payer systems, as one would predict, have the better outcomes in terms of lower costs per capita than the multi-payer systems of the European tradition. What drives higher spending in Canada? Is it that we use more medicines, or is it that we choose or are prescribed more expensive medicines, or is it simply that we pay higher prices for the same medicines? It turns out we did an analysis published last year in the Canadian Medical Association Journal that showed that in fact the major difference between us and comparable countries, in fact all of the 9 other comparables that we would compare to on the previous slide, the real difference is not that we consume more medicines. We actually consume just a tiny little bit more medication than those countries do. It's not necessarily that we choose more expensive options, although Canadian doctors tend to prescribe newer and more expensive treatments than their comparable, than their peers would do so in Europe and Australasia. That may be a function of the intense marketing of medicines, not just to professionals in North America, but also direct to consumer in North America, which is a phenomenon that you don't see elsewhere in the world. It's a phenomenon which is largely only made possible in the United States, kind of a little bit in Canada by what's known as disease awareness advertising. And interestingly enough, it's also legal in New Zealand, but not widely used because there's not a lot of profit to be made from that. And that's because the major driver of differences between what we spend on medicines in this country and what people spend abroad is in prices. The prices for brand and generic drugs between Canada and international comparators are on average 50% higher than they are in comparables. So this is to the point of the main thing that might come down if we were to have a universal single payer system for drug coverage is price. Volume of prescriptions would probably go up. Ideally, if it was an evidence-based formulary, some prescription volume would decline because we would try to encourage more appropriate use of medicines. In some cases, that means less, but we would also try to encourage more appropriate access to medicines. In many cases, that will mean more. The biggest difference will be the unit cost of the medicines flowing through. So in terms of the how, there are some models out there that people are postulating would be the things to consider, and we need to think them through very carefully. Some have proposed that Canada embrace a system where we stitch the gaps, so to speak, in coverage by compelling people to have private insurance if it's available to them, which is what the province of Quebec did in 1997. By law, if you are an employee in a workforce that is entitled to any form of extended health benefits, then you are by law required to also have private insurance for prescription drugs. If you don't qualify for that kind of benefit through the private market in Quebec, you are required by law to purchase insurance using a premium-based system directly from the government. So this kind of mandatory insurance model is suggested by some, including Finance Minister Bill Morneau, as maybe the path that Canada should follow, because we wouldn't want to get rid of all of that, money that's flowing through the private insurance industry. It's coming out of Canadians' pockets, of course, but the argument is we wouldn't want to get rid of that in some way, and we would want to take advantage of that. If we look at Quebec as the model for this, and we just published just a couple of months ago a piece in the Canadian Medical Association Journal, again, looking at the 20-year history since Quebec did this policy, you'll see, for instance, that Quebec does slightly better than the rest of Canada in terms of access to medicines. This is, again, the Angus Reid Institute survey, the same chart I showed before, of the percentage of households reporting that somebody in their household didn't fill a prescription because of out-of-pocket costs. The reason for that is that that system is designed like insurance companies design a system, not like healthcare managers design a system. It's designed to shift as many costs as possible onto the user by way of deductibles and co-insurance rates, so that the burden on the employment group or the group that's in the insurance plan isn't greater. And that's fine if all you care about is reducing the burden on employers, but it's not fine if you're concerned about access to medicine. So Quebec's system does a little bit better than the rest of Canada because essentially everyone in Quebec is insured, because by law they have to be, but the system is not designed like you would design a comparable PharmaCare system internationally. And in terms of the cost burden on the taxpayer and on the household and employer, there's some really telling charts from that Canadian Medical Association Journal, and I'll report them here. This is per capita spending by taxpayers on prescriptions in Quebec versus the rest of Canada. The rest of Canada is in red and Quebec is in blue. The difference line is this dotted green line. And the line that intersects that 1997 is the line that just tells you before versus after Quebec introduced this policy of mandatory insurance. And you can see for taxpayers in Quebec, there was essentially no savings. The system still cost the taxpayers the same amount as other parts of the system. So in some sense, the Quebec system was fiscally responsible if all you care about was taxpayer burden of the system. And there was no statistically significant difference in those two lines before and after. But what's really telling is the difference in terms of burden on households and employers. The direct burden on people who have to pay the premiums, either for the work-based programs or premiums and out-of-pocket costs for the public program that was mandated. In this instance, the household and employer cost of prescriptions in Quebec was almost identical to the rest of Canada for the 10 years or 12 years leading up to the policy change. And in fact, if you go to older databases, they were still the same back into 1975. But following the introduction of this mandatory private insurance system that involves for-profit private insurers who were given the opportunity to continue to raise their premiums every year based on past and forecast future expenditure under the programs, this was the perfect recipe for basically engineering structural inefficiency. Engineering a system where the insurers are quite happy to let costs go out of control because they can pass that on to their client every year by law, and they can pocket their administration fee every year in that system. And as a consequence, these costs in Quebec went right through the roof relative to the rest of Canada. Again, up until the policy change, these things were tracking right beside each other, and starting with the policy change, they started to separate. To a point now where Quebec is spending now $200 per capita more than the rest of Canada on medicines. And bearing in mind that Canada is spending $200 more per capita than other universal systems with universal coverage of medicines, this is a major, major difference. If the rest of Canada were to adopt a system that was like Quebec's and have similar policy outcomes, the rest of Canada would spend $5 billion a year more on the PharmaCare system, so to speak, than we are today. And that is quite a different story when you compare it to the estimates of the savings that is possible through a universal public plan. So bear that in mind. A system does improve access a little bit by having everyone insured, but it does so at an extraordinary cost in terms of structural institutional inefficiency, and also an extraordinary burden on individuals with low income, because the premiums you pay in that system are the same regardless of whether you earn $40,000 a year or $400,000 a year. And so that's important to bear in mind. The other thing that people have talked about in PharmaCare is maybe we should follow British Columbia's example and go towards a catastrophic drug coverage model for public insurance and let people voluntarily buy private insurance if they're interested in having extra coverage. And that is very much the model that British Columbia embraced back in 2003 when the government got rid of its system of universal public coverage for people over the age of 65 and then catastrophic coverage for all other ages. We moved towards a system that was age irrelevant, if you will, people of all ages in British Columbia essentially being given the opportunity to get some public coverage, but only against costs that would proverbially break the bank. It's the metaphor here. And the data show that British Columbians actually skip prescriptions because of costs at rates that are higher than any other province. Repeated, well-done studies on this subject have shown that British Columbia has, in some studies, as much as 2 times the rate of access barriers to medicines as comparably aged and wealthy people of other provinces. And this likely stems in part because of our system of universal catastrophic drug coverage. And it might also stem in part because of some of the other social pressures on British Columbians, or the economic pressures on British Columbians, such as the pressure of the cost of housing in BC. But nevertheless, British Columbia's system certainly doesn't increase access to medicines. In fact, all of the studies that were done of the change in the policy back in 2003 either found there was no increase in access as a consequence of this move towards giving everyone a subsidy rather than just senior citizens, or they found that actually there was reduced use of medicines, in some cases of reduced use of preventative medicines by the populations that previously had quite good coverage, such as people over the age of 65. So access barriers are problematic under that system. And one of the other things that's problematic is distributional equity. I'll just show you this complex chart quickly. If you organize British Columbians, this is the entire province of British Columbia organized based on how much money they spend on medicines. The top little $0 here reflects people who didn't spend anything on medicines, and that's roughly 30% of the population. And then each of the next notches is another 10% of the population in terms of average spending ordered by their spending levels. So what this tells you is that the people with the highest level of expenditure, the 10% of British Columbians who had the highest level of prescription drug spending at an individual level, not by household, but at the individual level, they had on average $3,000 of prescription expenses in 2007. So this is sort of, just how fast that things go up in terms of expenditure. And you've heard statistics like this in the past, for instance, that 20% of the population account for 80% of the expenditure on medicines. And in fact, 5% of the population account for nearly half of expenditure on medicines in British Columbia, as they do in other jurisdictions. What we did a couple of times, actually, but most recently in 2017, we published a paper showing if we follow the people from 2007 4 years on into 2011, and we order the 2011 data in the same way. The $0 represents the roughly 30% of the population who didn't fill any prescriptions in 2011. And then each notch there represents another 10% of the population ordered by their spending level. You can see that everything goes up in terms of the value of prescriptions filled between those 4 years. And the high end goes up quite considerably to $3,400, $3,500 as opposed to $3,000 for that top 10%. This next chart that I'm going to show you is the part that's sort of most important in thinking about high drug costs. And those of you who have had an opportunity to practice in pharmacy or medicine or nursing will know that patients with high needs are not patients like where they suddenly get sick and then they're better again and they can go home. And that does happen from time to time. We have episodes of high healthcare needs if you're lucky to survive. And you go on back to the averages. But most people who have high healthcare needs end up having these needs chronically. And what this chart shows is that it's hard to sort of say, but we tracked people starting in 2007, and we followed them to 2011 and figured out, well, where were they 4 years later? 72% of the people who were in the high use category in 2007 were still in the high use category in 2011. I don't have the data on here, but we also tracked the probability of death, and it was quite considerable. Basically, these high needs for medicines are typically until death do you part. These are medicine needs that you will have year after year. And the reason that this is important is that a model of financing medicines that says, why don't we just have people pay 3% of their income out of pocket before subsidies kick in, that is essentially saying we're going to put a 3% tax on people with chronic illness, simply because we don't want to spread the cost of those medicines more generally across the entire, for instance, taxpayer base that might finance a more comprehensive public program. So it's very important. The study by E.E. Wayman and the rest of my team doesn't get a lot of talk about it these days, but it is very important. If you think about the distributional equity, or frankly distributional inequity of British Columbia system, it is tantamount to having a tax on chronic needs, which in some sense is also tantamount to having a tax on old age. So catastrophic coverage, if you would, just in terms of a punchline, it will reduce access to medicines, and it will certainly reduce financial equity in the system. So that's one of the options. The last option, of course, is this idea of universal public insurance that has been talked about since the commissions of inquiry of the 1940s and 60s, and then repeated again in the National Commissions on Healthcare in the 1990s and early 2000s. And perhaps even repeated again, we'll see with the Standing Committee on Health report, what that model looks like, and what the model that research experts in this area have written, myself included, a model that has been endorsed by hundreds of university professors from across Canada, is a system that is universal in terms of everybody, regardless of age or income, is covered. A system that is evidence-based in terms of the fact that we really ought to be striving for a well-designed, well-managed, evidence-based national formulary, a formulary of medicines that says these are the medicines that every Canadian should have access to without financial barriers. That will mean that some medicines that currently are covered may come off. We may not want universal coverage for medicines that are currently overused or misused in the system. And we may want to narrow the scope of medicines for given conditions so that the first tier of coverage, the coverage that is most readily accessible to all, would privilege the medicines of greatest value for money, and then subsequent tiers of coverage would be there for medicines that are available to patients, but only when they've tried and failed on the most cost-effective options as their first-line therapy. So a truly evidence-based system is important. And that recommendation, interestingly enough, just as a footnote of history, back in the Hall Commission in 1965, Justice Emmett Hall talked about actually having an evidence-based national formulary for Canada back in the 60s, which is quite remarkable when you think about the fact that that virtually predates modern conceptions of what we would consider evidence-based medicine and health technology assessment of medicines. But there was certainly a sense of those committee hearings back in the 60s that some of the medicines that were routinely prescribed were either not safe enough or not effective enough at the price that they were being charged for to justify public provision. Another fair characteristic of a system that has been widely recommended is that there shouldn't be financial barriers to accessing treatment. Neither patients nor families should face a charge that's proportional to use or needs, because those kinds of charges are deterrents to accessing care, and of course there are also burdens on people who already have healthcare needs. And the last one is public management. And this is the point that is probably most contentious in the mind of the finance minister, because the finance minister has recently argued that we should have a parallel private system run by drug benefit managers, including his own or his family's company, Morneau Chappelle, where they can advise people on the private sector benefits. When in fact, the best way to manage a pharmaceutical benefit in any healthcare system is to integrate it into the system that you finance your other components of healthcare with. And that means a system that recognizes that medicines are, in fact, often the best way, the most cost-effective way to treat patients' needs, and therefore those are the things that we need to remove financial barriers to. But also, the worst way to spend money in a healthcare system is for medicines that are overpriced or overused or misused. And we need a system that would align the incentives of again, practitioners, patients, and managers of the system, so that they're taking care of medicines as a component of the overall healthcare of a patient, not as an isolated financial silo, and certainly not as an isolated financial silo from which the managers of that silo can take a profit. So that's the system that's been recommended time and time again. It's been estimated that that system would save Canada $4 billion, according to the Parliamentary Budget Officer's estimates, which was an estimate for a system that would use the Quebec formulary as the national formulary, which is a very broad formulary amongst public programs in Canada, and a system that would have very little or no co-payments for the vast majority of prescriptions filled. So kind of almost gold-plated PharmaCare would save Canada $4 billion per year. My colleagues and I have estimated that a system that was based on a bit more evidence in terms of using a more evidence-based formulary, having perhaps tiered co-payments to ensure that patients are steered towards value for money medicines first, that kind of system would probably save Canada in the neighborhood of about $7 billion per year. Whether it's $4 billion or $7 billion in savings from a national system of public drug coverage in Canada, it's important to recognize that what this means is that Canadians are already spending between $4 billion and $7 billion more than we need to have a system that improves access and patient outcomes. And this is the rub. We can do more with actually spending less if we do it through a system that is structured to be clinically defensible and, frankly, economically powerful in the world market for pharmaceuticals. So that was the why and the how, and now just the political part, the when. You know, how we're at a moment actually, and I think the events of the last couple of weeks with the budget, the federal budget that is, and the announcement of the establishment of an advisory council on the implementation of national PharmaCare, a council that will be headed by Dr. Eric Hoskins, until recently the health minister for Ontario. That council is a very big signal that this federal government intends to do something about this. I hope under the guidance of Dr. Hoskins, and perhaps under the vision and leadership of the federal Liberal Party, who might see this as their moment to create a lasting positive legacy, I'm hoping they'll go with the right option. The question is when and how do we, is now the time? And I would argue that now is an exceedingly rare window of opportunity for policy reform. And this is a funny color-coded chart of Canada, where I've color-coded the governments that lead at the federal level and in each of the provinces at the key moments when PharmaCare was a possibility in terms of policy reforms in Canada. That goes back to the Hall Commission of 65, the years at least immediately following it, the years immediately following the National Forum of Health, and the years immediately following the Romano Commission in 2002. And this is for people who are policy wonks, but we've had a liberal government in Canada at all of those windows of opportunity. It is essentially the liberal government at each of those windows that has said no to national pharmacare. But there's good political reason in our federation for that, because at those times, the two most populous provinces, Ontario and Quebec, were governed by conservative governments in Ontario, and even at the Hall Commission era, they were staunchly opposed to Medicare, let alone pharmacare, and separatist governments in Quebec. And particularly in the post-Hall Commission era, they could get away perhaps with introducing Medicare, but the separatists in Quebec were gaining steam and momentum and political power, and it probably was a non-starter for the federal government to move on pharmacare right at that time in history. And similarly, you had a conservative government in Ontario, separatist government in Quebec at the other key windows of time, and conservative governments in BC and Alberta and Manitoba and other provinces at various points of those times. I've ordered these provinces not west to east, but by population size, because that's also proportional to the number of seats in federal parliament. If you want to win the federal government, you've got to win those provinces as well, which means you probably don't want to piss off the provincial governments in those provinces, because then you're up against an increasing battle in a federal election. So it gives you an idea that not only is it, with the two different levels of government not necessarily get along, but you have some political, or at least electoral incentives challenges at that time. But this is why I think this is the window. This is why I think actually Justin Trudeau actually has a chance to make a policy legacy that in healthcare that is even bigger than his father's Canada Health Act by creating the National PharmaCare Program, and that's because of this. This is today, 2018. Right now, we have a liberal federal government. We have a liberal Ontario, at least until June, and perhaps now that there's a total change in leadership in the Progressive Conservatives of Ontario, who knows what will happen following June. It might still be liberal. It might even go NDP. We have a liberal government in Quebec, and we have progressive NDP governments in BC and Alberta. It's never before been such an alignment of those four largest provinces in terms of the probability that those governments would support federal action in this file, in dating back throughout the roughly now getting close to 60-year history on this issue. So this is an exceedingly rare window of opportunity for the federal government to do something with willing participants in most of the provinces. There's also a rare window now that the media is truly tuning in. In fact, following the finance minister's remarks about universal or national pharmacare not necessarily being a universal program, the editorial boards of the Globe and Mail, the Toronto Star, and the National Post, the three largest circulation papers in Canada, all three editorial boards said that the minister spoke out of turn and was in fact making a recommendation that wasn't based on best available evidence. All three papers essentially argued that the minister and the prime minister should allow Eric Hoskins to do his job, and if his job results in a recommendation of a universal public program, then that's what pharmacare should be. So the media are tuning in a way that they were not tuned in past times when pharmacare has been on the media agenda. And I know that because my colleague Jamie Daw and I, a couple of years ago, actually did a media analysis, a content analysis of media coverage of pharmacare in the 20 years leading up to 2010 to see whether or not National Forum on Health or the Romano Commission actually engaged the media. Today it is very different. Very much it's the case that media are engaged. And it's also the case that Canadians and the public are engaged. Whether it's senior citizens like the Raging Grannies who just celebrated, I think it's the 30th anniversary of their political activism, and other organizations who represent older Canadians like CARP, who are starting to say, wait a second, they want, older Canadians want a universal public program, even an age-irrelevant public program, because they see that in their interest and also in the interest of their children and grandchildren. We're seeing student groups getting more and more involved, particularly student groups outside of Ontario who are looking into Ontario and saying, wait a second,
In Ontario, everyone under the age of 25 now has public drug coverage. That saves student unions a heck of a lot of money. It's the #1 line item on extended health benefits for student unions. That if you disappear that, if you have that go into the public system, those student unions have a lot more money to spend on other things that students might find valuable. So we're seeing a mobilization essentially of the millennials, is recognizing that for them, this is critically important. It's important for them as students. It's also important for them as workers in a precarious workplace where increasingly they work for small enterprises, small businesses, which can't afford to provide extended health insurance, or they have to hold down 2 or 3 part-time jobs, none of which make them eligible for private benefits. It's those workers in Quebec who are finding the greatest struggle under that premium-based system, the system that Bill Morneau, our finance minister, is advocating for, is the one that actually puts millennials at the greatest financial risk, because they're the ones that bear the cost of those premiums against what are relatively modest earnings at the early stages of career. Another thing that's happening right now is labor is on board with universal public PharmaCare. This wouldn't have been the case 20 years ago when the National Forum on Health was talking about PharmaCare. Some unions were behind the idea, but some were afraid that PharmaCare as a public enterprise might give them less benefits. But increasingly, because of the high cost of medicines, the unions are recognizing that their benefits are being scaled back year after year under the private plans anyhow, and that they would be better off both in their work years and in their retirement through a system that was sustainable for all, through, again, the efficiencies that come from the public program. And then lastly, businesses are engaged. In fact, in British Columbia, the Surrey Board of Trade, the CEO of which, Anita Huberman, has been very vocal and outspoken about the fact that for small and medium businesses, and arguably also for large businesses, public PharmaCare takes this uncontrollable cost, a cost that they don't have the core competency to manage, off of their books and into the books of the public sector, which has the competency, in fact, the responsibility for managing in the context of our public healthcare system. And what they've argued, quite, I think, effectively, is that when you take that off the books of the companies, more companies can afford to offer extended health insurance for things like dental care, vision care, mental health services, physiotherapy, hearing aids, etc. More people can offer other extended health insurance, which interestingly enough means that the insurance companies may lose some of their revenues by way of public PharmaCare taking that business away from them, but they may find that they've got a whole bunch more demand for other forms of extended health insurance, which are more in control of the actors in that extended health insurance world. And lastly, in terms of timing, things are going to get worse without PharmaCare, without some system of compelling negotiation with manufacturers. This is a chart of the number of drugs licensed in Canada that cost greater than $10,000 per year is the light green, between $20,000 and $50,000 a year is the light blue, and over $50,000 a year is the dark blue. The number of medicines at those price tags over the last 10 years has grown nearly tenfold. And the R&D pipeline of the pharmaceutical sector makes it quite clear that this is going to continue in the years to come. There isn't an employer group in Canada that can sustain the pressures of having to fund medicines that are tens, if not hundreds of thousands of dollars per patient treated. And unions and employers don't want to be in the very difficult, in fact, entirely unethical position of having to decide who gets those therapies and who doesn't. The only way to make that kind of clinical and public rationing decision is in a system that is clinically defensible, ethically defensible, and accountable to the public as a whole, and through a system that also has all of that purchasing power that comes from a single-payer pharmaceutical benefit, like a single-payer PharmaCare program. So I ended the talk, and I think it was just about right on time in terms of the length here. The story here really, if you think about pessimism, about, every other country does this, we should be embarrassed that we can't. The upbeat side is that every other country does this, so it proves that so can Canada. In fact, every other country, every comparable country with a system of universal public insurance for healthcare provides universal public coverage of medicines that achieves better access to care at far lower costs. So this is one of these rare win-win scenarios in terms of policy in Canada. The key thing will be whether or not political leaders want to take on some of the more powerful interest groups, and most notably the manufacturers of medicines, and to some degree the insurance industry, who will oppose such a change because at the end of the day, it's their prices that are going to see the biggest hit. And I would argue, again, with increased prescribing volume and increased rational therapy and increased desire to promote appropriate use of medicines, pharmacists as professionals should not fear this. In fact, pharmacists as professionals should probably embrace this as a great opportunity to see their patients having better access to the care they need, and also have opportunity to see their patients more often because they're no longer not bothering to go to the pharmacy because they know they'll be able to fill their prescriptions. So with that, I will say thank you and open up for any questions you may have.
So we have one major clarification point. Someone wanted to know if the allocation of funds to the PharmaCare program would take any hits to our current provincial allocations for healthcare.
Well, that's a great question. Yeah. So would PharmaCare eat the lunch of the rest of the healthcare system? And I think it's important to recognize, and it's a bit of I've got to come up with a way of illustrating this. So Canada, if you look at the Parliamentary Budget Officer's estimates, the PBO estimated that we spend about $24 billion on the medicines that would be included in a public pharmacare system. And that because of the increased utilization, that would go up to $26 billion worth of prescriptions. But the PBO thinks the purchasing power of the system would be able to buy you that new basket of medicines that Canadians would need at about $20 billion. So the 24 versus 20 is the savings, which is to say that we've already got the money. In fact, we already have more money into the pharmaceutical benefits system than we need for PharmaCare. What the governments need to do, and I think what the federal government needs to do, is introduce a new tax in this country. I don't know if it's going to be, I mean, in British Columbia recently with the replacement of the MSP premiums, they did a payroll tax to compensate. Technically speaking, that's a fairly narrow tax base. You might want to do something more broadly based, something like a combination of corporate income taxes and personal income taxes, so that you create a new tax in this country that would raise an incremental amount of money that essentially takes the money that was in private insurance right now and moves some of it into the public plan, but you don't have to move all of it. About $11 billion in potential savings is there for the private sector if you take $6 billion and put it into the public program. So we need a new tax, which I think if you talk to labor and certainly businesses outside of the insurance and pharmaceutical sector, I think you'd find that they would be happy to find a tool that was a fair way of moving money into the public system so that it left a fairly significant amount of savings in the private sector. And again, just to go back, what all of the analysis done that is credible, whether it's from the peer-reviewed scientific research or the Parliamentary Budget Office, it all shows that we already have more than enough money for PharmaCare. We just have to change the way that the system is collecting money for medicines, and of course, change the way it's paying it out. Yeah.
So just reiterating the question that was asked earlier today, lots of talk about around PharmaCare, and I believe it's an excellent idea. However, PharmaCare is essentially an agreement to reduce drug costs among other initiatives. As a community pharmacist, our revenue is designed around product and retail markup. It'll be difficult for community pharmacy as a profession to continue to be sustainable under national PharmaCare. Are there any talks to include fees or reimbursements for clinical services by pharmacists in these PharmaCare talks? Otherwise, a business cannot thrive. If a community pharmacist makes a certain margin, we cannot charge the patient more when drug costs go down. Otherwise, patients will not benefit from PharmaCare. It'll be fantastic if, say, essential medications are $1 for 100 tablets, but how can community pharmacists thrive as a profession off such thin margins? Frequently prescribed meds in BC have dropped almost half, and that's a good step for patients. However, a lot of community pharmacists are uneasy due to decreased revenue, job security, etc.
Well, again, so this is a verbatim, virtually the same comment as the last comment, making me think it's probably the same person, or somebody has scripted some of these comments to come in to this webinar, which is not unusual. I read my Twitter feed, I get a lot of scripted things that seem to come from bots that are from the sectors that may be affected by this. I want to be clear. PharmaCare will reduce the price of medicines in Canada. That's what the Parliamentary Budget Officer said. That's what anyone who's thought this through knows that a universal public system will be much cheaper in terms of the price we pay for medicines. Nobody has said we should reduce dispensing fees, and in fact, as a source of revenue, professional fees to pharmacists will go up because every estimate about a PharmaCare system says the prescribing volume will go up. In terms of the viability of community pharmacy, Canada has 30% more pharmacies per capita than they have in the United States. We have more pharmacies per capita than many comparable countries. And so will we see a consolidation? It's hard to know. A colleague of mine and I a few years ago did a study to find that they found an astonishing percentage of Canadians live within 800 meters of more than 5 pharmacies in their neighborhoods. Will that go down to 4 under a PharmaCare system? I don't think so, in part because when we saw the original decrease in generic pricing occur back in 2006 and repeated in 2010 and repeated again just recently with new announcements about the gradual decrease in generic prices in Canada, pharmacies in Ontario argued that that was going to be the end of the community pharmacy business. The pharmacy lobby in Ontario said that it was the death of community pharmacy and Canadians would have a difficult time accessing the pharmacists because they would all close up shop. When we did analysis subsequent to that, we found that the number of pharmacies in Ontario increased following those reductions in costs. So it's hard to know whether or not the pharmacy profession is at threat or whether or not the margins of the major corporations that own the vast majority of pharmacies in Canada are at threat. I do know, if you look at systems abroad, if you look at the United Kingdom, if you look at the European systems, you look at the systems in New Zealand or even Australia, they all have viable community pharmacy. In none of those systems that spend 40% less on medicines than Canada, do you see there's no pharmacies available. So there will be obviously negotiations around how do we develop a revenue model for pharmacy at the price of brand name drugs come down. However, the reality is that we're going to see more volumes going through. Dispensing fees even on a $1 prescriptions, the professional fee is many times that. In fact, the average professional fee is about 10 or 11 times that $1 worth of tablets. So margins matter, but so do professional fees, and there will be a negotiation, no doubt, to make sure that the system is not unduly punishing, particularly community pharmacies in rural and remote locations. Just like was the case when Ontario brought down the generic pricing there, they started to create special allowances for pharmacies that were in fact serving populations for which there weren't 5 pharmacies within 800 meters.
Earlier you spoke about BC's catastrophic drug coverage. If we were to switch over to a nationwide drug coverage plan, how do we ensure the continuation of BC's different plans, such as the cystic fibrosis plan, palliative care plans to our patients? Would we be able to keep it sustainable?
Well, I mean, so if we went to a universal public program that had good coverage, of course, that would fold into that system. But that said, one of the things that one can envision in terms of the gradual evolution, if you will, of a universal PharmaCare program is for the provinces and territories to work together on what they would consider the national formulary. That is the list of medicines that every Canadian by right of citizenship should have access to without financial barriers. The medicines that essentially there should be universal public coverage as a minimum standard for. Nothing would preclude any province from adding on top of that, more coverage for certain populations. And there may be, geographic differences in burden of disease that might give rise to that. But again, if you look abroad, if you look at comparables internationally, the programs that we would see in Europe, in Scandinavian countries, in the United Kingdom, in Australia, they all have universal systems that provide coverage for many of the drugs that Canadians feel lucky to have coverage for under some of our public programs. Those are sort of the default levels of coverage internationally.
Next question comes
Sorry,
from
do you mind if I add on to that point first? So an add-on to that point is there are a lot of variabilities that you mentioned between the different provinces and their health drug needs. What would be would there be any benefits or drawbacks if we were to incorporate all of their needs, and would that possibly eliminate spending if we were just to keep those conditions addressed by the provincial governments there?
Yeah, so I think one of the challenges is this idea that we have regional variations in coverage today. We certainly have regional variations in the populations eligible for coverage. In fact, that's the biggest problem in Canada. It's not so much that the formularies differ in the provinces. About 90% or more of the formularies in every province is identical. every province covers, largely speaking, the same drugs for the dominant healthcare needs within each jurisdiction. What they don't do is they don't provide that coverage for the same population. Some are provided for people over certain ages, some under certain ages, some with certain incomes, some with certain diseases. Moving forward, if you were to think about PharmaCare as evolving as a national standard for the minimum coverage for all people, again, there's a possibility for having differences by province that reflect provincial priorities and provincial needs. But again, I would emphasize that if this is done right, and in fact, if the federal government does do what the parliamentary budget officer recommended, which is essentially infuse somewhere between $6 to $7 billion into the public drug programs of Canada, that's enough money to provide a fully comprehensive formulary for all Canadians. It's basically the Quebec formulary, which would be quite considerable. And again, if it's done right, one could expect that over the years of that program evolving, the system would become better at management and better at determining what should be in the formulary. The provinces, territories, and federal government, along with patient representatives, representatives of Indigenous populations, et cetera, can sit down and figure out how do we decide as a nation what should be in that. And again, none of that would preclude if your local government wants you to have more access, or even frankly, if your local union wants your workplace to have better access to certain things. Nothing would preclude having that layer on top of what would be a national standard.
Adding to the comment, someone brought up, is it possible just to expand our current NIHB at a federal level so that we can encompass all Canadians? NIHB has already federally administered portable, accessible to all provinces.
Yeah, so it's an interesting question. And so for those not familiar, the non-insured health benefits is the program that provides extended coverage for Indigenous populations. And it is essentially a federal drug plan. It only accounts for about 2% of national expenditure on medicines right now. But one of my arguments is, well, maybe the federal government could just take over PharmaCare and run a federal drug plan for everybody in the country. And interestingly enough, the premiers asked the federal government to do that back in 2003 when they had a first ministers meeting. The premiers, I think, threw out what was essentially a red herring or a smokescreen to say, why don't the federal government take care of PharmaCare? Because the premiers were busy not wanting to talk about other issues like wait times at that point in history. However, it is an interesting concept. Could you run a federal PharmaCare program? For various reasons, not the least of which is our Constitution. Health does fall within the jurisdiction of the provinces. Provinces would have to cede that jurisdictional autonomy for medicines over to the federal government. It's unlikely that the provinces would wish to do that. So what is most likely would be a formula that works just like Canadian Medicare. The federal government establishes some form of national standard, like a formulary of drugs that needs to be available to everybody at not more than a $5 copayment or something like that, and tells all the provinces you must comply with this standard. But if you do, we'll give you your portion of our $6 or $7 billion contribution. And it's through that what's called spending power. It's through the power of the federal government to transfer money to the provinces with some conditions that you can effectively create a national universal program that is actually run by the 10 provinces and 3 territories. Over here.
So it was there's a clarification for the first question. They were asking, is it just dispensing fees that they were considering not cutting? Because there's other clinical services like adaptations or medication reviews.
Oh yeah, so yeah, they're a great question. And when I talk about professional services or you know, the professional fees, every province has a different basket, for instance, of various kinds of not just dispensing fee, but whether it's adaptation or renewal, there's pharmacists prescribing in many jurisdictions with different limits and terms. Those things aren't going to go away overnight. And in fact, you know, one of the things that I think we can expect to see more of, particularly if, I mean, Eric Hoskins, you know, what's interesting about having him as the new PharmaCare czar for the federal government is he's a practicing clinician. You know, he's an MD physician who has been in practice, went into politics, and he understands not just the value of getting more access to medicines Canadians need, but he understands the compelling case of making sure that Canadians are not using their medicines inappropriately, and making the case for, you know, the planned and clinically rational de-prescribing of treatments. in this country. And so as we move forward with PharmaCare, I'm hopeful, and I've communicated to Dr. Hoskins, and I will continue to do so as their council unfolds, that what we want to do is make sure that we do PharmaCare right, and that we do PharmaCare as part of a suite of investments that includes spending more money on professional services related to appropriate use of medicines. Canada lacks a national strategy in that regard. We have really interesting things going on at different provincial levels, but it would sure be nice to ramp that up through a national strategy. And there again is an opportunity, I think, in some sense, for pharmacists as professionals to get more involved in patient care and less involved in the dispensing of prescriptions, but more involved in the managing of prescriptions. And ideally, for instance, even getting out of the dispensary and into the primary care clinics where there's multidisciplinary teams, again, so that there's a greater emphasis on pharmacists as professionals that are part of the clinical and primary care team, and less about them just as the kind of conduit to the dispensing services, but focusing more on the professional services writ large.
So next question, Alberta's cost-saving measures include withholding 10% of payments to pharmacies per year in order to buffer against financial shortfalls. Will Universal PharmaCare be holding funds to community pharmacists in order to make Universal PharmaCare financially viable year to year?
Yeah, so I can't speak to the specific administrative details that will come out in terms of how they do the accounting and transactions, and whether what form of invoicing and whatnot that they will use. My suspicion, again, is that people are going to sit down and hammer out an arrangement that works for the major parties in this, and it's not going to be. Well, I'm virtually certain, just thinking from the perspective of someone who's studying political economy, this will not be draconian. They cannot make a PharmaCare program and turn it into a program that will alienate pharmacists as professionals. There may be chain drugstores that are worried about their margins and the profits to their shareholders, but to the profession of pharmacies, if anything was to become threatening in terms of the viability of their business, government won't go there. This is not, the interest of PharmaCare is not about, clawing back revenue from the profession. It's about ensuring access to treatment and bringing Canadian drug prices, the prices we pay for the very same drugs in this country, down to the level that you see in comparable countries abroad. So again, I don't know the details, and that's partly what Dr. Hoskins and his council will be working on, I think, and obviously in consultation with the key stakeholder groups. But I would think that they'll never do anything draconian. They will never do anything that really puts the profession at risk, because that's not in their interest. It's not in the sustainable interest of a universal drug bank.
And then the next question says, will Universal PharmaCare also be extended to hospitals so that they can benefit from cheaper costs as well?
Well, that's a great question. Would hospitals benefit? So I would conjecture at the very beginning, the answer to that would be no. Hospitals use group purchasing organizations or health authorities that have purchasing bodies within them to essentially do all the contract and procurement on behalf of hospitals, whether it's in British Columbia or any other province. There's already a reasonably sophisticated apparatus for procurement of medicines at the hospital level. When we build a PharmaCare program, it's likely that the procurement process for PharmaCare can learn some lessons from the hospital sector, but it's likely at the outset it'll be quite independent. It'll leverage more things like the existing infrastructure in each province and territory as it relates to managing the existing public programs. That can be built upon. It'll leverage the systems at the Canadian Agency for Drugs and Technologies in Health, CADTH, as well as the Pan-Canadian Pharmaceutical Alliance, the PCPA, which has a secretariat that does engage in procurement and particularly negotiation with manufacturers. All of those things are likely to be leveraged in the community setting that we already have in the community setting. Over time, if you were to fast forward 20 or 30 years, it would be interesting to see whether or not we would see some provinces anyhow align those inpatient and outpatient procurement strategies. But I don't think it would happen at the outset. It's one of these things you build with what you've got, and what we've got is infrastructure to do this in the community setting that's different than in the inpatient setting. Get that working, and then see how that evolves over time.
In other provinces, dispensing fees are as high as $30 per prescription. Do you see Universal PharmaCare bringing this up to $30 or cutting everyone's dispensing fee down to 10? And how will pushback from other provinces be dealt with?
Well, yeah, so the dispensing fee, $30 per prescription would be an outlier. Average dispensing fees in Canada do vary by jurisdiction and by payer type. So different provinces have different levels of fees for public, and different private insurers allow for different levels of fees. And in fact, in Quebec, it's almost impossible to penetrate the math of what actually is the ingredient cost versus the dispensing fee for a prescription, because they're not reported separately. They're reported as a single fee for prescriptions. So what will happen as PharmaCare rolls out is that each province is going to have to figure out how to manage that within the context of its program. I don't see this as being a program that's going to threaten the existing professional fee revenue for pharmacies. And if anything, that the emphasis will be on ensuring that professional fee revenues are maintained or enhanced under a program, precisely because some of those markup revenues will come down under the program. So as a consequence, the system is going to have to make sure, again, that the business model of pharmacy is viable without being unduly rewarding. No system, I think, is going to want to see the pharmacy fee go up to $30 per prescription when the national average right now is something like 11.
One of the greatest critics is the possibility of inferior coverage when we attempt to unify drug formularies through all of Canada. Can you comment on this? Yeah, so
let's be clear, there's a fear mongering that's going on by stakeholders in the industry. Most probably behind the scenes, it's conservative think tanks like the Fraser Institute and their various researchers, and they're likely funded by pharmaceutical industry players, who are trying to suggest that the access to innovative medicines is inferior in the countries that we would model our PharmaCare program after. And that's simply not the case. There isn't evidence that would suggest that the average Canadian has inferior access to treatments on a day-to-day basis that you see in other countries. And in fact, as already articulated, millions of Canadians are suffering financial barriers to accessing routinely needed medicines right now. So on the whole, we would expect access to the vast majority of Canadians to improve. Are some of the drugs that might be covered by certain private insurance plans in Canada covered by every PharmaCare program that's publicly managed internationally? The answer to that would be no. But oftentimes the answer to that is no, because those treatments come to market with insufficient evidence of safety, efficacy, and comparative value for money to justify again, public procurement on behalf of all people in the country. And one of the important things to know is that no PharmaCare proposal that I've ever seen, and certainly none that I've ever written, has ever said that there wouldn't be the option for Canadians to use their own money to buy whatever medicine that they want, provided it was licensed by Health Canada, and nothing would preclude employment groups that exist today from continuing to have private drug coverage for things that might not make it to a national formulary. Again, presuming that national formulary will be based on good scientific evidence, and sometimes good scientific evidence will say that a drug shouldn't be covered for everybody because it doesn't represent the best use of resources.
And this is the last question. As Quebec are having discussions about withdrawing from the Healthcare Act and their recent cutbacks on pharmacy services, how do you consider implementing it nationwide?
Yeah, so the Quebec question is a fascinating one because there's a whole host of challenges in working on a national policy vis-a-vis Quebec's right to its own sovereign autonomy over these programs. And this is this is why I hope that Eric Hoskins is chairing a council of advisors that includes representatives of the federal and provincial and territorial governments. I think it's those players that need to be sitting down and working through what would work. And I know that there's already right now the federal, provincial, and territorial health ministers have agreed, and they agreed last October, that they would work on developing essentially a model of national PharmaCare. They would work on developing some economic analysis of what that system would cost. So parallel to what's going on with Dr. Hoskins' committee, there is also this other work at the federal, provincial, territorial level. And it'll be really interesting to see whether or not the program that Quebec participates in is one of national standards, which it might fulfill with a different mechanism, or would Quebec be happy to change the mechanism of financing? There's a good number of people in Quebec that are feeling dissatisfied with the outcomes, particularly the financial cost and the equity outcomes in Quebec, that they might be willing to embrace a different model. Like other major changes in healthcare, if you want to bring all the provinces on board, though, it's going to require considerable federal investment. The federal government can't bully the provinces, but it can provide a financial incentive for them to participate. So there's a lot of political things to be thought through, technical and administrative things, of course. The greatest challenges are probably at the political in terms of regional autonomy. And again, that's why I would hope that this advisory council, as well as the health ministers meeting or health ministers working group, I hope that they're meaningfully, working through some of these jurisdictional issues that are important. And again, the sort of sometimes referred to as asymmetrical federalism in terms of allowing there to be outlier provinces should those outlier provinces wish to not participate. Thanks. Get my glasses
Okay, thank you, Dr. Morgan. So I just want to say thank you again for everyone who's joining us today, especially those in Eastern Canada. I know it's probably past your bedtime. I just wanted to say thank you again, and I would refer you guys to the PharmaCare2020.com website, which is a proposal for a legislation to pressure our federal government to invest in a drug coverage plan. And also a quick comment about today's event. While we did start off a little rocky, I wanted to recognize the reason why we are here. We are pharmacy students, and we want to help eliminate barriers to health. We want to find ways to advocate for our patients in the future. And speaking on behalf of our great profession, I just want us to try and remain open-minded in different methods and ways that we can help them and ways that we can advocate. Again, this event is happening during Pharmacist Awareness Month, which is all of March, and we want to thank you for all your time and remind you that pharmacists do more than just count pills. We are involved in health economics, and we want to do the best to shape Canada as well as our healthcare profession. Thanks.